final presentation, Color 3, a randomized clinical trial comparing traditional laparoscopic and transanal Tme for rectal cancer by Dr. Deijen from the Amsterdam group.
Good morning. Thank you for the opportunity to present our proposal for the Color 3 trial at SAGES. I have nothing to disclose. So as mentioned before, rectal cancer surgery is technically challenging, and especially low rectal cancer can be considered the Achilles heel of rectal cancer surgery. Low rectal cancer is more difficult to resect. As depicted here, you can see the angle if you approach a tumor through the abdomen. Is difficult because of the bladder, and in male also the prostate. And of course also the narrow anatomy of the pelvis, resulting in the circumferential resection margin being at risk. So several large studies has shown various rates of involvement of CRM after laparoscopic resection of rectal cancer. The classic trial showed a rate of 16%. The Color 2 trial showed a percentage of 9%. Korean trial showed 3% involvement of CRM, and the group of Roulier in France showed a percentage of 18%. So what is the importance of the CRM? We know that increased CRM results in an increased rate of local recurrence. In the Color 2 trial, we saw in the laparoscopic group, so the patients who were operated laparoscopically for rectal cancer had an involvement of CRM in 9% in patients with low rectal cancer, defined as tumors within 5 centimeters from the anal verge, and this resulted in a local recurrence rate of 4.4%. In the open group, the involvement of CRM was 22%, and this resulted in a local recurrence rate of 11.7%. So to overcome this problem, the Transanal Tme was developed, and several cohort studies, including our own, have shown promising results. We included 80 patients, and all the patients had a tumor within 10 centimeters from the anal verge. And in only 2 patients, the CRM was involved at pathological assessment, and this was 2.5%. So the next step is to evaluate this new technique in a multi-center international randomized controlled trial, the Color 3 trial. The main research questions will be, does transanal Tme improve the radicality of the resection, and does transanal Tme result in more sphincter-saving procedures? The main inclusion criteria will be the solitary mid or distal rectal cancer, suitable for elective surgery with curative intent, and the main exclusion criteria will be T4 tumors, T3 tumors with distance less than 1 millimeter to the mesorectal fascia after neoadjuvant therapy, and evidence for distant metastases. It will be a superiority trial, and the primary outcome will be the involvement of circumferential section margin. If we want to achieve a reduction of the CRM by half, from 10 to 5%, 1,005 patients will be needed. And they will be randomized in a 2-to-1 ratio in favor of the transanal technique. Secondary outcomes include macroscopic evaluation of the mesorectum, morbidity and mortality, the local recurrence rate, disease-free and overall survival, sphincter-saving procedures, functional outcomes, and the quality of life. But new techniques come with a learning curve, and that's why we will conduct a pre-trial first, and quality assurance needs to exclude bias and underperformance. And this trial will include a prospective cohort of surgeons, learning curve will with objective quality control, and video assessment and proctoring before entering the Color 3 trial. There are several centers that are providing TME trainings, so surgeons who gained the competence for the TME technique can enter the Color 3 trial and participate. Our goal is to start this year, and we hope we can start this summer. And finally, we would like to invite everyone to the Tme Congress in Amsterdam in May, and registration is possible through the website rectalcancersurgery.eu. Thank you for your attention.
Well, congratulations on the work that your group has done in this field up until this point moving forward. I'm wondering if you could comment on, while the need for prospective randomized trials is always great, in this technique, which is really in its embryonic form, what do you think about starting the trial now as we're still figuring out how to do this, as opposed to waiting until it matures? And a concern is going to be that the early data is going to potentially cloud the real benefits of the approach as it develops.
Thank you for your question. Well, we have been discussing the moment to start the trial. You don't want to start too early, what you say, if the procedure is still being learned by a lot of surgeons. But on the other hand, you don't want to start the trial too late if the approach is too popular and the laparoscopic approach will be used less. And that's why we think we have to start the trial this year. But before surgeons can enter, we do evaluate their technique, and we will do that by an operation manual which is being developed now in cooperation with Imperial College in London to assure the quality of the procedure.
I guess the corollary to that is, the real question is, are you aware of anyone in the world who's comfortable with their approach with this technique and they feel that they've optimized it at this point?
Yes, I know there are surgeons that have done a lot of these procedures and are comfortable with it.
I'd like to meet them.
Yeah.
Pat?
Thank you for presenting the trial. It's actually very helpful for the American audience to see the premise of the trial and the plan moving forward. It really helps. My concern is similar to John's. I think the only question is, we're seeing now videos coming from all over the world where the technique, you're doing some transanal dissection, you're doing the whole TME from the bottom, then you're coming on top, you're taking the vessels, first, or you're taking it second. So there's a lot of heterogeneity in the way people are doing this procedure. And so far, the results across the board are excellent. So clearly, the first justifies the primary endpoint being the quality of the TME. But the question is, how do you standardize when people are really doing it very well, using different approaches, top, bottom, bottom up, robot from the bottom, robot from the top. I mean, it's really all over the map. So are you going to require surgeons to do it in one specific way? And how are you going to regulate how much of the TME is done from the bottom up?
Thank you for the question. We are developing the operation manual, and certain steps will be acquired to perform the procedure. We're still working on if surgeons have to start with the abdominal phase or the transanal phase, but there will be an operation manual how to perform the procedure to standardize it.
Good luck with that. Thank you much. Any other questions? Thank you all for attending and for excellent presentations and staying on time.